Type 2 Diabetes Mellitus, a case study of Sally Jones, by Bridget, Megan, Hannah and Ellie, Group 57, Endocrine. Sally Jones, a 47-year-old receptionist diagnosed with type 2 diabetes 5 months ago, presents for a follow-up visit. She's been compliant with metformin, however reports that whilst her home blood sugar readings have improved a little, they are still high. She complains of how thirsty she is and how often she has to go to the bathroom. Sally has a family history of diabetes, with both her mother and older brother also type 2 diabetics. She was diagnosed 5 months ago after presenting with blurry vision and a random glucose level of 15 millimoles per litre. She's had no significant hypoglycemic episodes. Sally has been compliant with her metformin, however has been experiencing elevated blood glucose readings at home. She's not lost weight since her diagnosis. She's been trying to exercise 20 minutes daily, however says she's often too tired and prefers to watch TV. She also admits to a few dietary indiscretions and often visits McDonald's after work. This is an example of uncontrolled type 2 diabetes. Sally has several risk factors that made it more likely she would develop diabetes. She's over the age of 45, has a family history of diabetes, leads a sedentary lifestyle, has poor dietary control, and she's overweight. The polyuria, polydipsia, and hypoglycemic episodes she's experiencing is indicative of poor glycemic control, requiring further investigation and management. In this case study, we're going to examine the pathophysiology of type 2 diabetes and how this relates to Sally. We will discuss the medication she's currently taking, as well as other pharmacological options as the disease progresses. We'll identify relevant and patient-focused nursing interventions and Sally's current symptoms. We will also discuss the national and quality health service standards that are relevant to this case study.
Glucose is the body's main source of energy. We obtain glucose by the foods that we eat that are rich in starch, such as potatoes, rice, bread and pasta. The starch gets broken down into individual glucose molecules by digestive enzymes. It also gets absorbed into the blood and travels to the liver via the hepatic portal vein, where it is converted into glycogen. When blood glucose levels fall, the glycogen gets converted back into glucose. The pancreas is located behind the stomach, between the spleen and the duodenum. It plays an important part in glucose regulation and is both an exocrine as well as an endocrine gland. As an exocrine gland, it produces several digestive enzymes that are secreted into the duodenum via the pancreatic duct. The endocrine gland produces and secretes the hormones glucagon and insulin. The role of insulin and glucagon. Insulin is produced and secreted by the beta cells of the pancreatic islets. The beta cells detect an increase in glucose levels, causing the release of insulin. The main task is the facilitation of glucose into the body cells. It inhibits glycogenolysis and it prevents the conversion of amino acids or fats to glucose. Glucagon is produced by the alpha cells in the pancreatic islets. It responds to a decrease in blood glucose, it increases and maintains blood glucose levels, it promotes gluconeogenesis, and it mainly acts in the liver to convert stored glycogen into glucose and release it in the blood. Type 2 diabetes is a metabolic disorder. It is multifactorial and it's present across the lifespan. In type 2 diabetes, insulin is present, but the body cannot use this effectively. Glucose cannot get into the cells and remains in the blood, leading to elevated levels of blood glucose. This is also known as hyperglycemia. Patients could be asymptomatic or be severely hyperglycemic, and onset is slow. Initially, the body produces more insulin to overcome insulin resistance, resulting in insulin insufficiency. It is characterized by a combination of peripheral insulin resistance and inadequate insulin secretion by the beta cells of the pancreas. Insulin resistance leads to decreased glucose transport into the cells, increased glucose production, and increased breakdown of fat. Obesity and increased BMI is the single most common cause of type 2 diabetes. The clinical manifestations of type 2 diabetes are polydipsia, increased thirst, polyuria, increased urine production, polyphagia, increased hunger, fatigue is due to lack of glucose uptake, glycosuria is glucose in the urine. There are visual disturbances such as blurred vision or black spots in the vision field, recurrent infections such as delayed wound healing due to impaired blood supply, and genital pruritus such as vaginal infections. The risk factors of type 2 diabetes. Sally was diagnosed with type 2 diabetes due to several modifiable and unmodifiable risk factors. Her modifiable risk factors are: she has a BMI of 33, she is obese, she is physically inactive, and she leads an unhealthy diet. Unmodifiable risk factors are: she has a family history, both her mother and brother have type 2 diabetes, and she's 47. Other risk factors are ethnicity, history of diabetes, prediabetes such as impaired fasting glucose or impaired glucose tolerance, hypertension, previous gestational diabetes, smoking, polycystic ovary syndrome, certain medications such as beta blockers and antipsychotics and statins, and a low socioeconomic status. Chronic complications. Both Sally's obesity and hypoglycemia have a negative effect on her health. Her obesity, in combination with her BMI of 33, are related to an increased risk of cardiovascular events. Hypoglycemia, due to her uncontrolled diabetes, can lead to microvascular complications such as diabetic retinopathy due to ischemia of the retina, the proliferative and non-proliferative type. Diabetic nephropathy is due to the damage of the blood vessel supplying the glomeruli. Diabetic neuropathy are the sensory neuropathy and the autonomic neuropathy is due to metabolic disturbances. The macrovascular complications are cerebrovascular accident, stroke, and cardiovascular diseases.
The aim of pharmacological therapy in type 2 diabetes is to achieve normal or near normal glycemia with HbA1c goal of below 7%. In most patients with type 2 diabetes, the disease is progressive. Blood glucose levels and HbA1c rise over time. In this case study, Sally has been prescribed metformin, which acts by reducing hepatic glucose production and increasing utilization of glucose in peripheral tissue. It's a typical first-line treatment for type 2 diabetes. It should be used with caution in patients with impaired renal function or conditions that increase the risk of lactic acidosis, such as severe heart failure or liver failure. It should be stopped prior to surgery and replaced with insulin until after recovery. Common side effects include nausea, vomiting, abdominal discomfort, and diarrhea. To minimise these, Sally should take metformin with or after food. She should also limit alcohol intake as it can decrease blood glucose and mask symptoms of hypoglycemia. For safety, renal and hepatic function should be checked prior to treatment and ongoing every 4 to 6 months along with HbA1c. Daily self-monitoring of blood glucose levels is required. Dosage should be increased slowly to limit gastrointestinal effects. A common second-line treatment is a sulfonylurea, which stimulates insulin secretion. These are indicated for patients who cannot tolerate metformin or when metformin alone is not controlling the glycemia. They're contraindicated in ketoacidosis and type 1 diabetes. They should be avoided with renal or hepatic impairment and should be used with caution in acute illnesses such as MI, infection, and trauma. The most common side effect is hypoglycemia. The risk of hypoglycemia increases after exercise if meals are missed, with high drug dosages, excessive alcohol, impaired renal or cardiac function, and concurrent treatment with other drugs. Warning symptoms include sweating, hunger, faintness, tremor, headache, visual disturbance, and altered mood. It's important for Sally to start with a low dosage and increase slowly until control is achieved. Monitoring includes regular checking of renal and hepatic function via blood test, self-monitoring of blood glucose levels, and regular HbA1c checks. Thiazolidinediones are an alternative second-line therapy. However, they're losing favour as they have significant adverse effects. They act mainly by increasing insulin sensitivity and decreasing hepatic glucose output. Contraindications include ketoacidosis and type 1 diabetes, pregnancy, and breastfeeding. They should only be considered when other drugs cannot be tolerated or they're contraindicated. Patients must be without risk factors for heart failure and bone fractures. Adverse effects include weight gain, fluid retention, and increased risk of heart failure and bone fracture. These medications would only be considered for Sally in the future, dependent on her tolerance to metformin and sulfonylurias, as well as any comorbidities or risk factors she may have at the time. If there's no effect after 6 months, treatment should be stopped. Liver enzymes need to be monitored and treatment ceased if jaundice occurs. Fluid retention should be assessed prior to increasing dosage and treatment ceased if heart failure is diagnosed. Self-monitoring of blood glucose is required as are regular HbA1c checks. As the disease progresses, insulin will eventually be required for most patients with type 2 diabetes. It's also indicated in type 1 diabetes or when oral drugs cannot be used, for example during pregnancy or surgery. It's usually delivered by subcut injection and it acts by increasing glucose metabolism and by inhibiting glucose output and lipolysis. Insulin therapy often involves basal long-acting insulin combined with pre-meal boluses of a rapid-acting insulin. This is intended to mimic normal insulin secretion of the pancreas. Adverse effects include weight gain, allergic reactions, local reactions at injection sites, itching, lipodystrophy, and lipoatrophy. The most frequent and serious is hypoglycemia. Additionally, fear of injections and perceived complexity regarding self-management can be barriers to starting insulin therapy. Sally would require significant patient education as well as emotional support. Sally would need to monitor her own blood glucose, including before meals. She would require regular HbA1c checks, and she must also have ongoing access to consultations for insulin regime adjustments.
Nursing management. Nursing management of type 2 diabetes is focused around implementing lifestyle changes to reverse or slow down the body's resistance to insulin. The key areas that would be the focus of a nurse caring for Sally is her sedentary lifestyle and promoting physical activity, encouraging healthy eating through meal planning and providing her with educational support to help her learn to live with and overcome her new diagnosis. There will be two main outcomes focused on for Sally's nursing treatments. These are normalizing the blood glucose levels and dietary management. The treatment goal of normalizing BGLs are always individualizing the blood glucose targets. The nurse must ensure that Sally's BGL treatments are patient-focused to ensure successful outcomes and to reduce fluctuations in her BGLs. In terms of goals for dietary management, it centers around providing optimal nutrition and with all essential food groups that will meet Sally's needs. Within this, the nurse must work with Sally to achieve and maintain a reasonable weight whilst keeping her engaged and enjoying food. Meal planning. Diet is a key contributor to developing type 2 diabetes. Therefore, in order to reverse or slow the onset, dietary adjustments need to be made. The nurse will work in conjunction with a dietitian and Sally to create a meal plan that suits her needs and is working towards losing excess weight and maintaining a balanced diet. When meal planning, it is important to include the patient and ask them about their lifestyle habits, common meal times, and ethnic and cultural practices. The time it takes to prepare meals and budget should also be taken into consideration in order to see greater patient compliance. Involvement of the patient will see greater compliance with the strategies put in place. A balanced diet is important for a patient managing diabetes. Sally needs to include a wide range of fruit and vegetables as well as whole grain cereals like bread, pasta, and rice. Her diet should limit the amount of fat and sugar she consumes. It should be encouraged that her diet consists of 50 to 60% carbohydrates, focusing on the whole grains, and fat should be around 20 to 30%, with less than 10% being saturated fat. Drinking plenty of water is also encouraged. 8 glasses a day is recommended. A meal plan would include breakfast, lunch, dinner, as well as appropriate snacks, taking into account Sally's daily kilojoule requirement. Sally would need to be informed about how eating fatty and sugary meals are impacting upon her current condition.
Regular exercise is very effective in managing diabetes. It increases the body's use of a glucose through uptake by body muscles, as well as reducing cardiovascular risk factors. After a thorough medical assessment by a doctor, Sally would be able to commence an appropriate exercise routine as planned for her by an exercise physiologist and a personal trainer. When planning a new routine that Sally is to adhere to, it is vital that she is involved in the planning process to see the greatest patient adherence. It is recommended that the patients complete 30 minutes of moderate intensity exercise every day where possible. Yet the nurse should ensure that all these recommendations are specialised and individualised for Sally to achieve superior benefits of it. A key component of managing diabetes is the monitoring of the patient's blood glucose level to determine if interventions that are in place are working to control the amount of glucose in the bloodstream. Self-monitoring allows this, as Sally will be able to check her blood glucose levels as required wherever she may be. It is recommended that she checks her BGL reading at least 2 to 3 times a week, including one reading that is 2 hour postprandial. While Sally is commencing her new diet and exercise routine, it is advised that she increases the frequency of testing to see how her body is responding to the changes, as this will enable her and her doctors to adjust the routine as required for her. In regards to physical activity, it should be recommended that Sally checks her BGLs before, during, and after prolonged physical activity for her to be able to self-manage her levels. In relation to National Safety and Quality Health Standards, Standard 3 being preventing and controlling healthcare associated infections. And within this 3.1.1, risk management approach is taken when implementing policies, procedures and/or protocols for the safe handling and disposal of sharps. So this just relates to Sally's disposal of the BGL equipment safely, whereas the nurse will do this herself or will oversee whilst in care to make sure that there is safety of Sally and the other patients.
Education. Providing Sally with information on type 2 diabetes and the effect it has on the body, as well as ways she can improve her lifestyle and quality of life, will see greater patient adherence to changes put in place by medical professionals. Education would also need to be provided to Sally regarding different treatment options, medications and their associated risks and benefits. This is in accordance with NSQHS 4.13.1 about providing patients with specific medication information, including options, benefits, and risks. When a doctor prescribes Sally a new medication, the nurse can provide Sally with fact sheets and administration charts to help with the stress associated with a new diagnosis and lifestyle changes. The nurse can provide Sally with information from Australian Diabetes Society, as well as linking her with support groups. As a newly diagnosed diabetic, Sally is entitled to outpatient training programs. It is important that the nurse offer these to Sally so she can gain as much support and education as needed. As a part of the training would include insulin administration. While Sally is not currently on insulin, if she is unable to control her diabetes, she may require injections. While Sally is being taken care of, she will be receiving new information that she may forget. It is important for the nurse to reiterate education to Sally regularly to ensure that the learning is being taken on and desired outcomes are being achieved.
The nursing management outcomes that we would hope for Sally is for her to continue with the nursing interventions put in place to manage her diabetes, as it is important that the health professionals involved teach Sally about self-managing her condition, so she doesn't continually have to rely on a multidisciplinary team outside of her regular checkups. If Sally sticks to the interventions put in place by the nurse, doctor, dietitian, and other medical professionals she encounters, She should be able to achieve her goals of weight loss, stabilising her blood glucose levels, maintaining a healthy diet, and gaining support from individuals also diagnosed with type 2 diabetes. In conclusion, the National Safety and Quality Health Standard that also relates to Sally's case is Standard 9, recognising and responding to clinical deterioration in acute healthcare. Within this 9.2, collecting information about the recognition and response systems, providing feedback to the clinical workforce, and tracking outcomes and changes in performance over time. 9.2.1, feedback is actively sought from the clinical workforce on the responsiveness and recognition and response systems. This is where the nurse will track Sally's responsiveness to treatments that will be evaluated through feedback that will be gathered regularly to ensure the effectiveness of managing her diabetes.